In this presentation, we will discuss strategies to minimize perioperative coagulopathy. We will focus on evidence-based strategies to minimize perioperative coagulopathy in cardiothoracic surgery patients at risk of developing major bleeding. These recommendations can be used as a bundle to minimize bleeding and prevent unnecessary blood transfusions. 10% of cardiac surgical patients will experience major bleeding, and up to 40% will receive blood transfusion, especially unpumped cases, reoperations, or complex procedures. Hemostasis in cardiac surgery is complex and influenced by major surgical trauma, cardiopulmonary bypass-associated coagulopathy, anticoagulation management, and additional perioperative factors such as acidosis and hypothermia. Bleeding and transfusion in cardiac surgery are prevalent and they're associated with worse outcomes. Preoperative identification of high-risk patients should be performed, and all available measures of blood conservation should be undertaken in this group as they account for most blood products transfused. Anemia is identified in up to 40% of cardiac surgery patients. Iron deficiency is the most common cause, and it occurs in up to 50% of them. Patients with preoperative anemia are more likely to require transfusions, and if the ability to treat iron deficiency anemia is available without any untoward effects, it should be instituted before surgery, if time allows. For recommendations on when to stop antiplatelet and anticoagulant medications before surgery, please refer to a dedicated video on this series. Laboratory and or point-of-care measurement of antiplatelet drug effect in patients having received recent antiplatelet therapy can be useful to assess bleeding risk or to guide the timing of surgery. For patients in need of emergent cardiac surgery and recent ingestion of a NOAC or laboratory evidence of a NOAC effect, administration of the reversal antidote specific to that NOAC is recommended. If the antidote for that specified NOAC is not available, PCC is recommended. During on-pump cardiac surgery, the coagulation system faces major alterations that can lead to coagulopathy. The contact between blood and the non-biological surface of the extracorporeal circuit and the pericardial surface activates platelets as well as the intrinsic and extrinsic coagulation pathways. These pathways lead to the consumption of coagulation factors and the formation of bradykinin. Bradykinin activates tissue plasminogen activator, cleaving plasminogen to plasmin, breaking down freshly formed clots and causing fibrinolysis. This is usually counteracted by the administration of an antifibrinolytic drug such as tranexamic acid. Retrograde autologous priming of the cardiopulmonary bypass circuit should be used wherever possible. Reduced priming volume in the cardiopulmonary bypass circuit not only reduces hemodilution, but is also indicated for blood conservation. Routine use of red cell salvage using centrifugation is helpful for blood conservation in cardiac operations using cardiopulmonary bypass. Direct reinfusion of shed mediastinal blood from postoperative chest tube drainage is not recommended as a means of blood conservation and may cause harm. The amount of blood loss during and after surgery needs to be closely monitored. When bleeding is excessive, a patient's hemostatic potential needs to be tested and promptly treated, preventing further hemorrhage and transfusion. If heparin is to be used for on-pump cardiac cases, adequate protamine dosing is not only important for heparin reversal, but for hemostasis. Protamine itself has several anticoagulant properties. It can inhibit platelet function, cause coagulation factor dysfunction, and enhance fibrinolysis. Inadequate tissue perfusion leads to lactic acid formation causing acidosis. Acidosis impairs clot formation and adequate hemodynamic management, especially in cardiac patients with left ventricular dysfunction. Therefore, it is important to optimize for hemostasis. However, excessive fluid administration or PRBC transfusion can cause further dilution of coagulation proteins, also impairing hemostasis. Additionally, packed red blood cell transfusion can cause hypocalcemia by the concurrent administration of citrate. Calcium is important in the activation of other clotting factors in the coagulation cascade. Therefore, a calcium debit should be supplemented to prevent coagulopathy. Finally, hypothermia inhibits enzyme activity, and therefore temperature management is important to optimize clotting after surgery. In conclusion, a multimodal approach comprising the identification of patients at risk, as well as the prevention, monitoring, and treatment of microvascular bleeding caused by coagulopathy, can lead to improvement in outcomes. All components must be combined in a multidisciplinary approach involving the cardiothoracic surgeon, anesthesiologist, hematologist, perfusionist, and intensivist. Thank you for your attention.